And next, I'd like to call on Dr. Michael Milosevic from Princess Margaret Hospital, and he will give us the clinical perspective.
Thanks, Jake. First of all, like Soren, I would like to thank you and the organizers of the committee for inviting me, or the meeting for inviting me to speak today. It's a great pleasure to be here and talk about uncertainties from a clinical perspective, and in the clinic how we are addressing concerns about new technologies and new biology and innovation in our patients on a day-by-day basis. So as Jake pointed out, this is an exciting time for radiation medicine. We've come a long way over the last 50 years with advances mainly in technology, but also in our understanding of the biology of how radiation interacts with tissue and how that influences clinical outcomes. And I think that our field is ready to take off and accelerate in these developments. And in fact, I think that the future of radiation medicine over the next 20 years is going to continue to be a combination of anatomic targeting and image guidance combined with a better understanding of the molecular interactions of radiation with tissue, imaging biomarkers that reflect the underlying biology, and new molecular targeted therapeutics in combination with radiation. And this is exciting, and it offers real benefit for our patients as we move forward. But we as custodians of radiation treatment have a responsibility to actually understand the uncertainties that bringing these different forms of treatment together will bring to bear on how we actually deal with our patients. Just simple things like how do we combine radiation with new molecular therapeutics? What doses? What sequencing? What are the likely control rates or side effects? And that raises a whole constellation of uncertainties that I think really at this point is limiting how we combine these two therapeutic strategies in the context of clinical care. We need to think about these uncertainties and the clinical consequences of the uncertainties that we've talked about. And Soren touched on this in his talk. But at the end of the day, the dosimetric consequences, the geometric consequences are fine. But what's important from my perspective as a clinician is how these translate into clinical outcomes for the patients that I am treating. And the clinical significance of some of the consequence or some of the uncertainties that we deal with is really very context specific. I treat a lot of cervical cancer, so I'm going to show you a lot of examples about cervical cancer today. And as we push in terms of targeted treatment towards more targeted external beam therapy with intensity modulated radiation and image guidance, or towards MR-guided brachytherapy, the uncertainty, the geometric and dosimetric uncertainties are much different than they were when I was worried about treating with a 4-field box 10 or 15 years ago. For example, issues around internal organ motion, we didn't know much about it. It was certainly an uncertainty, but we didn't worry much about it either because of the nature of the volumes we were treating. Uncertainty didn't factor into control rates. Now, as our treatments become much more targeted, these issues are much more important in the minds of clinicians and need to be addressed on a regular basis. And in fact, I would say that in cervix cancer, uncertainties around internal organ motion are limiting the advancements of external beam targeted treatment like IMRT. There are a few centers doing it, but many centers are not, just because of concerns about how to be sure that the target is being treated each day and normal tissues are not. Soren addressed this in a much more eloquent way than I will, but this is just to point out that the clinical consequences of geometric and dosimetric uncertainty really depends on the clinical context and the dose-response relationships that we're talking about. And a 10 or 20% uncertainty in dosimetric in dose delivery can have different consequences depending on whether you're at the top of that dose response curve for tumor control or down in the mid portion of that dose response curve, and the same thing for normal tissues. When I look at the clinical challenges that we face right now, I think that there are two broad categories. One of them is really to do with harmonizing care in the face of uncertainty, of clinical uncertainty. And this is, in Soren's language, how do we improve the precision of what we're thinking about in terms of clinical care for our patients. And the second is how do we measure and report clinical outcomes in a meaningful way? From a harmonizing care perspective, I think that there are many aspects to this that I would argue have greater uncertainty than some of the geometric and dosimetric considerations right now. If you think of the trajectory from the decision to treat with radiation treatment until the completion of the last fraction, if you move along that trajectory each step of the way, I think that some of these clinical uncertainties actually are more significant, much more significant than the dosimetric or geometric. Things such as target delineation, we're able to deliver a dose plus or minus 5% with 4 millimeter accuracy to a target that's derived by the physician, but the fact is there's a whole lot of uncertainty in what that target is and how it's defined and whether it's correct or not. Internal target and normal tissue motion, tumor regression and deformation, just the simple question of how big does a CTV margin need to be to encompass subclinical disease? For most clinicians, this is a bit of a black box and we pull a number out of the air. There have been studies done in a few clinical sites like lung and liver, I guess, and pancreas that have suggested provided some data that we can use to define these margins. But in most situations, it's very ill-defined and likely varies on a patient-specific basis. And then also the clinical response to a shrinking tumor, which I'll come back to in a moment. Measuring and reporting clinical outcomes is very important from the perspective of if we harmonize the care that we provide to our patients, we will improve our ability to demonstrate clinical benefit in the context of clinical trials. And this is the same thing that Soren was talking about right now. If there's a lot of heterogeneity in how patients are treated because of the clinical variability across centers or across physicians, that decreases the effective power of a clinical trial to show significant differences in outcome. So we are shooting ourselves in the foot when we do clinical studies if we have not addressed all of these concerns in a careful manner right up front. Now, the other thing that we need to consider is that we work in an environment that's constrained. We have many priorities in radiation treatment. 3 of the major ones that we all struggle with in our clinics on a daily basis are shown there. If we had infinite resources, we could deal with these uncertainties and minimize these uncertainties to the point where they would no longer be of clinical concern. The fact is that we can't. So all of the things that we're talking about today, all of the efforts to reduce uncertainty, particularly clinical uncertainties, need to be considered in the context of a constrained environment, the environment that we all deal with daily. How do we go about harmonizing care if that's what we think we need to do from a clinical perspective? We need to harmonize care among physicians and among groups that are involved in the care of patients. Well, standardization is very helpful. Clinical practice guidelines, consensus statements, clinical trials, peer review, and education and training all contribute to this, and there are examples of these out there in our community that have demonstrated the benefits in terms of, in some cases at least, improved clinical outcome. And I will touch on a few of those as I go forward. The ICRU has helped us immensely with standardization, not only from the clinical perspective, but in relation to every step of the radiation treatment trajectory. And the ICRU definitions, target definitions that were published in ICRU 50 and ICRU 62 provide a grounding, a foundation for us to talk about dealing with uncertainties in the routine day-to-day care of patients. And we're all familiar with these in terms of gross tumor volume and clinical target volume, an internal target volume to deal with motion issues, internal motion, and a planning target volume. And these are immensely valuable. How we incorporate these into clinical practice is more challenging, and it depends on the clinical context, the scenario in which we're treating, the characteristics of the patients, and whether or not, for example, we're using image guidance or what type of image guidance. And this is from the recent ASTRO white paper that was published earlier in this year, which really defines the paradigms, a paradigm for image guidance, and really points out the uncertainties along the way in that paradigm, from target and normal tissue definition through margin definition and treatment planning, through imaging and adjustment and dose delivery. And certainly target and normal tissue delineation is a major hurdle that we need to address as we move forward. And there's obviously an interplay between the margins that we require to account for uncertainties in terms of microscopic disease extension or internal target motion or patient setup, and to some extent the image guidance technology that we're using and how that's applied in routine practice. So target delineation, I just want to touch on that briefly because I think it is a major issue that the clinical group, the clinical community needs to address or continue to address as we go forward. It's been defined as the weakest link in the search for accuracy in radiation treatment, and I think that's actually right. As I said earlier, it's easy or relatively easy with current technology to deliver dose accurately to a defined volume. The challenge is getting that volume right to begin with. And there are many studies like this in the literature now for most tumor sites. This happens to be one in cervical cancer, where we simply asked 19 experts, the people who are publishing in the Red Journal on cervical cancer, to contour the cervix, the uterus, and the parametria using on MR images in a couple of patients. And you can see the variability in where people thought the targets would be under those circumstances. If you're treating with a 4-field box, doesn't make much difference. If you're starting to move into an IMRT era, it makes a huge amount of difference, potentially, in terms of clinical outcomes for these patients. So how do we go about improving this? We know that we actually need to define these volumes more accurately. The problem is there's really no gold standard available to us right now that we can go to and say this is how it should be done. So we need to rely on a variety of expert opinions, for example, and consensus among experts who think about these tumor sites every day. And this is facilitated by having high-quality imaging available to us, both anatomic and metabolic imaging, through simplification and automation, and peer review I'll touch on in a moment as well. So the importance of imaging can't be underestimated. And this, I think, really illustrates it quite nicely for cervical cancer. And as we move to the left to the right, we move from the typical sort of cone beam CT image that we have available to us now in our departments that we see on a treatment unit, through a diagnostic quality CT, through MR. And in terms of volume definition, it's hard to know from either of these two where the target is. In fact, in this slice, in this particular patient, the gross tumor is this little thing right here. You'd never know that looking at either of these two images. So if you're trying to define tumor volumes precisely, you need high-quality imaging. It also speaks to the fact that we need to think outside the box in terms of how we're interacting with our colleagues. And the role of the radiation oncologist is becoming so imaging-based that I think it's very, very important that we start embracing medical imaging more, collaborating with our medical imaging colleagues, and bringing them in when we're trying to define volumes in this kind of context. So this kind of collaboration needs to be strengthened. And I know at our place that our residents are now spending a significant amount of time with medical imaging during their training to try to refine their understanding of the interpretation of these kinds of images. And I know that's happening in many other training programs in North America and Europe. Metabolic imaging can actually help us refine these volumes even more so. And this is an example that many of you have probably seen in lung cancer, where just the introduction of a biologic target volume helps us to realize that anatomic imaging alone is not sufficient. And we can further refine this by automating some of these processes, in this case by using an automated thresholding technique to define what we think is a clinically relevant metabolic target volume. And I think this is a way that we will need to move over time, but these kinds of techniques with multimodality and multiparametric imaging are very, very helpful. We see in the literature now multiple contouring guidelines, consensus guidelines published for many, many tumor sites where there are controversial issues. We also see the same kind of information being presented in clinical trials protocols, where experts get together and define what they feel are ideally the kinds of contours that should be done. What we don't see so much of are studies that actually validate the fact that having these kinds of contouring guidelines make a difference in terms of harmonizing care for patients. This is one that I found that was published in 2006 from the group in Vancouver that actually showed that if you actually test patients, you give a group you have a training group and you have a group that is untrained. I can't read it, it's so small there, that you actually see improved precision or improved contour agreement in the group that get the training guidelines. And then if you test them again and give both groups the same kind of guidelines, that you see convergence between the two groups. So these kinds of things, if they're used properly, actually do make a difference in the harmonization of care for patients, contour agreement, and the precision with which we deliver clinical care. Peer review is something that I think is extremely important, and this, I think, is something that, from a clinical perspective, we need to emphasize. And it is the idea of sitting down with colleagues and looking at treatment plans, looking at contours, and having a discussion about what's right or wrong, and actually making changes to plans that are contoured inappropriately. This is an example from a recent article in the Red Journal, again from one of the groups in British Columbia, that showed that on the left, the breast seroma wasn't adequately covered by the 95% isodose in the original plan, and that was corrected after peer review. In fact, if you look through the literature, and in our experience at Princess Margaret, there are fewer than 5% of plans where these kinds of changes are detected, or these kinds of errors are detected, and the plans need to be changed. The real value of this is in really getting a group of people together to discuss cases and learn and to talk about uncertainties and actually promote some kind of convergence around how we do things in the context of clinical care. And this as such has attained a level of priority in Canada to the point where it's now in many provinces a metric that's publicly reported or will shortly be publicly reported. So the Canadian Partnership for Quality in Radiotherapy has defined an indicator one of their indicators of quality in relation to peer review of treatment plans and the proportion of treatment plans that are reviewed either before treatment or within 25% of the delivered dose. In Ontario, for example, this will shortly be publicly reported on the CCO website as a function of Cancer Centre, so that people can go there and see to what extent peer review is actually happening. Just a few words about motion and motion management, because this is something that I think many of you will think about or have been thinking about on a day-by-day basis. And this study illustrates, as well as any study that is out there, the effect that motion can have, or unmanaged or uncontrolled motion, internal target motion, can have on clinical outcomes for patients. And we've done a pretty good job, I think, as a community of thinking about the systematic effects of internal target motion, building these into population-based PTV margins as a function of image guidance that may be in place. And recognizing that these margins for a population of patients vary depending on the type of image guidance that's available and how it's implemented in a particular clinical context. What I think we need to do is move away from the population basis and think more about what's happening in an individual patient, because sometimes our traditional paradigm of image guidance with population-based PTV margins breaks down and doesn't actually provide optimal care for an individual patient. And we see that when we get radical kinds of or extreme kinds of motion like this in a patient with cervix cancer, where on one day the cervix is anteverted and on the next day it's retroverted. And if that uterus, on the upper part of the uterus, is part of your target volume and you're using a targeted technique using an IMRT kind of protocol, then you run the risk of missing that. Or in situations like this, where we get tumor regression, again in cervix cancer, over the course of external beam treatment, and changes in dosimetry with normal tissues such as rectum moving into what might be the high dose volume, so the potential for increase in normal tissue side effects. And so this moves us away from that paradigm, the usual paradigm of image guidance, into a paradigm where we have to start thinking about whether or not that treatment plan that we developed on day one is actually adequate for the entire course of external beam, or do we need to, at some point, strategically replan, some strategic time point, replan that patient. And if we get into that era of what people have called adaptive radiotherapy, the uncertainties escalate rapidly in terms of a variety of factors relating to how we actually do this and implement this in the real world. Probably one of the groups that has done this most effectively is the GEC-ESTRO group in relation to cervix cancer brachytherapy. And they, over the past several years, have moved brachytherapy for cervix cancer from sort of a standard cookbook recipe for everyone to an MR-based image-guided strategy that really reflects adapting the treatment to a changing tumor volume, to tumor regression during the course of treatment. It's been easy for them to implement because there was a natural breakpoint in treatment at the end of external beam before brachytherapy was implemented. So that uncertainty was not one that they had to be particularly concerned about. But there are numerous other uncertainties associated with this. And in fact, there's a beautiful Green Journal article that was just published, or a whole issue of the Green Journal in April, that talked about all of the inherent uncertainties in MR-guided brachytherapy for cervical cancer. They've done a wonderful job as well, I think, of defining relevant volumes and making this easy for the community to adopt. And they recognized right up front that there were relevant volumes here that were different from what the ICRU had defined and that we need to think about as clinicians and physicists in order to make this safe for our patients. And the first is the concept of the intermediate risk CTV, which is the tumor volume at diagnosis, and the second is the high-risk CTV, which is the tumor volume at brachytherapy, the volume that the tumor shrinks down to over the course of external beam radiotherapy. They also have done a good job of defining dose constraints for these volumes, target doses for these volumes, and also dose constraints for the organs at risk. And this, together with a lot of education and training, has really allowed this to move forward, particularly in the European community. North America is lagging significantly behind, but I don't think that we can afford to stay behind for long because they've done an excellent job of demonstrating the utility of this kind of an adaptive approach. I should say just briefly that the work that the GEC-ESTRO group has done has been taken up by the ICRU, and there's a revision of ICRU Report 38 pending, which really talks about prescribing brachytherapy for cervical cancer. This is not yet published. I tried to get a hold of a preliminary copy of it, but was unsuccessful. But suffice it to say that the concepts that they have developed in terms of brachytherapy have evolved into new definitions that really provide a lexicon for adaptive radiotherapy as we move forward and dealing with some of the uncertainties associated with adaptive radiotherapy, things like the initial GTV and the residual GTV and the adaptive CTV. One of the things that this study has highlighted, this work of GEC-ESTRO, one of the things that this has highlighted, and for many clinicians, is what to do with the shrinking tumor volume. If you have a volume that's size X at time 0 and it shrinks to size Y at time T, what do you do with that? Can you actually bring dose off of that volume, or do you need to continue to treat that entire target volume, the volume that was present initially? And this is a huge concern when you talk to clinical people. They say, I just don't know what to do. The paradigm until this point has been to deliver full dose to that entire volume that was present at diagnosis. Is it safe to come down? Is it safe to pull dose away? Is it safe to leave some of that untreated? And this is similar to the CTV story. How big a CTV margin do we need? But in many clinicians' minds, the stakes are higher here because we know that there was tumor there initially. And the question is, how much is that regressed? Are there residual cancer cells or not? And some of the work that's coming out of the GEC-ESTRO group has tried to define this. I know that some of the groups are doing targeted biopsies of the intermediate risk CTV, which would sort of conform to this. Others are looking at imaging techniques to do this. And this is a study from Aarhus looking at diffusion-weighted imaging. Diffusion-weighted imaging and the apparent diffusion coefficient really gives us an indication of the probability or the density of tumor cells at a particular site. So tumors tend to have lower diffusion coefficients, restricted diffusion because of densely packed cancer cells, and normal tissues have less restricted diffusion or more free diffusion. And you can see that as you move from the GTV to the high-risk CTV to the intermediate risk CTV, which is the area that everyone's concerned about, you actually do move up in diffusion coefficient. But it really raises the issue or the concern again about what dose needs to go to each of these target volumes. And GEC-ESTRO has done a good job of dealing with this by actually specifying the dose to the intermediate risk CTV and the high risk CTV so that people can begin to conform to some guideline, and we will learn as we move forward. The proof is in the pudding, as they say, though, and the data are beginning to come out. And if you look at this is a curve that these are survival curves that were published by this group. And the interesting part is the tumor control for large tumors greater than 5 centimeters in size. And these are very, very good numbers, particularly in the latter, for the latter cohort here, very high tumor probabilities for large cervical cancers. The difference between these partially reflects learning and just how do you actually implement MR-guided brachytherapy. But one of the other things they did in moving from the earlier era to the later era is they started to include more of those areas which they subsequently defined as gray zones, the areas where they're not sure about whether or not there might be gross tumor there. They started to include those in their definitions here, and outcomes actually improved. So this actually is just an indication of the kinds of uncertainties that we as a community need to deal with. And of course, we can break down the restriction on doing this only once during treatment at the end of external beam, and we can begin to talk about adapting treatment at multiple points, multiple strategic points during a course of external beam radiotherapy and brachytherapy with deformable registration and dose accumulation at each time point and adaptive replanning. And the uncertainties associated with that escalate in terms of the timing of that, the accuracy considerations in terms of deformable registration, the accumulated errors that are possible with multiple deformations to determine a cumulative dose as some of the possibilities. I just want to say in closing that all of this does matter. And this is a study that I think is actually very, very important. It really speaks to the issues of harmonization of care and the effect that harmonization of care and improved precision can actually have on clinical outcomes. This is a randomized study in head and neck cancer, and it was actually a study of a hypoxia-targeted treatment called tirapazamine in patients with clinically localized head and neck. They were getting radiation plus or minus this agent. It doesn't really matter what the treatment was. The study was negative, which was very disappointed. And they went back, the investigators subsequently went back and looked at the compliance of treatment against the protocol that was written. And what they were able to demonstrate is that if there was a protocol violation, a significant protocol violation in terms of how treatment was delivered, and that was never corrected during the course of treatment, those patients did significantly worse in terms of their outcome compared to those who were treated according to what the experts who developed that protocol thought was most appropriate. So harmonized care does matter, and we need to be worried about that and think about it. So in summary, I think that the clinical significance of uncertainties depends on patient, tumor, and treatment factors. Right now, for some tumor sites at least, uncertainties about target volume, internal motion, and response to a shrinking tumor, for example, actually are limiting our ability to move forward with some of the more targeted treatments that would ultimately benefit these patients if we could wrestle with these uncertainties, these clinical uncertainties. I think that advances in biology and technology will enable more personalized radiation medicine, but at the same time, they're going to introduce uncertainties that we will need to grapple with. And in the face of uncertainty and in the face of not having a gold standard, harmonization of clinical care among physicians and among practitioners in general has the potential to improve clinical outcomes. Thank you very much.